that really matter following heart surgery in children, calling it integrating heart, brain, and behavior. This is the brainchild of Dr. Krishna Kumar and Dr. Sonam Manoj, who, who incidentally had done a day-long CME on this topic very recently. Dr. Krishna Kumar is the clinical professor and head of the Department of Pediatric Cardiology at the Amrita Institute of Medical Sciences and Research Center, Cochin. After doing his DM cardiology from All India Institute of Medical Sciences, he did his fellowship in pediatric cardiology from Children's Hospital, Boston. He is the proud person to have established a premier pediatric heart program at the Amrita Institute, which focuses on teamwork, excellence, and continuous quality improvement. The program was awarded the BMJ Award for Quality Improvement in 2014, Children's Heartling Center of Excellence in 2015, and the ICMR Center of Excellence Award in 2023. Dr. Krishna Kumar is the recipient of the Sitaram Jaipuria Award for Excellence in Medicine and Healthcare in the year 2022. He delivered the Duckett Jones Memorial Lecture at the American Heart Association in 2025. He leads a fellowship training program in pediatric cardiology and DM in pediatric cardiology, and he's an international fellow of the American Heart Association. He's also the past president of the Pediatric Cardiac Society of India and has around 300 peer-reviewed publications and has edited 4 major textbooks. He is extremely proud of the fact that he has trained 65 pediatric cardiologists. Other than all this, Dr. Krishna Kumar has been a big supporter of marvelous medicine for the past 5 years, and he always comes up with these unique topics that we can have on this program. Since Dr. Krishna Kumar knows Sonam and Dr. Deepa, I request him to introduce them.
Thank you, Vidya. That was, thank you for the introduction. The one thing that struck me when I developed the pediatric heart program is that there was growing awareness of the fact that these children were having issues relating to cognition, and then eventually translating into difficulties with learning as well as social adaptation. And we increasingly saw this in our patients over the last 25 years. So I felt a very strong need to establish a cohort, which I did in this country, of about 2,500 babies who have undergone infant heart surgery across five centers in the country, in various parts of the country. And I got a grant to do that. As I did that, I thought we should formalize this whole process of taking care of them. That's when I ran into Sonam, who is a remarkably talented, diversely talented person, who's a clinical psychologist by training, but has a very strong interest in learning and in neurodevelopment as such. So Sonam joined us in the fag end of the ICMR project, but then decided to pursue a PhD in this area. So she's enrolled for a PhD in neurodevelopment and in extended follow-up of our patients. And then set up what was through a grant with the Azim Premji Foundation, extension of the same cohort. So she calls it Project Medha, and I'm going to ask her to talk about it during her presentation. And has now established, is in the process of establishing a whole range of services for children that are being followed up for cardiology, after cardiac surgery. Now, the reason why I thought Marvelous Medicine would be interested in this is because the problems that we see, I'm certain, affects other specialties, other pediatric specialties, and all children with chronic disease need to have this kind of a service so that we close the gaps that seems to be significant in their lives in terms of getting integrated into the society and, developing into useful citizens. So with this background, Sonam really will just set the stage for our talk. And the other person we're very deeply fortunate to have is Dr. Deepa Bhaskaran, who's a hardcore developmental pediatrician, unlike the two of us. And so getting her domain expertise onto this talk would be terrific. So she is also very diversely qualified, MD in pediatrics, a PG diploma in adolescent pediatrics, a PG diploma in developmental neurology. But most importantly, she is the director in charge of the renowned Center for Child Development in Trivandrum since the year 2022. A specific area of interest is autism spectrum disorders, but as we saw in our recently conducted seminar, she just has a whole range of expertise in all areas that are pertinent to child development, both in the early years as well as later on as they grow up. So, with this, I would hand over the stage, so to speak, to Sonam, who will do the first talk.
Thank you. Thank you so much, sir. That was a warm introduction from you. Thank you so much for this. Let me just share my screen. Are we able to see my screen?
Yes, yes.
Okay, all right. All right. So, sir has already, done a little bit of the introduction that I wanted to talk about, and the importance of why we're looking at even talking about what is missing after survival. So, in the next 1.5 hours, we will look at understanding what is that we really need to focus on to in terms of in the field of congenital heart disease. Is survival the only outcome that we're looking at, or have we moved on and are we looking at something that is masked yet, and are we missing something? So, and in the next 35-40 minutes that I'm talking, we will set the stage for understanding what does the field of cardiac heart care for children looks like, what does congenital heart defects looks like, where did we start from, where we are today, and what is that we need to do as we go forward. So, on that note, I'd like you to see meet Arav, who's one of our little boys. He's 6 years, 3 months right now. Now, this child was diagnosed with DTGA, and I know that most of the audience here are medical doctors, but we also have some psychology friends here. So for them, I'm going to make this a little bit more simpler. My friends and my students are also here as a part of the audience. So to just make this simple, this child was diagnosed with DTGA, which we otherwise call the dextrotransposition of great arteries. This is a serious congenital heart condition present from birth. Now, in simple terms, what happens here is that the major blood vessels, which is connected to the heart, are reversed. So, because of which the oxygen poor blood circulates through the body instead of the oxygen rich blood. Now, what can happen here is that this could lead to dangerously low oxygen levels in the body, and we could lose the child. So, this child was diagnosed with DTGA, and at 1.5 months of age, we had to do this intervention for him. Now, like sir was mentioning, that we are looking at a longitudinal follow-up of children and looking at how they're developing. We had this cohort in which Arav was also followed up, and we checked his development at 6 months, 12 months, and 24 months after the heart surgery that he had. Now, if you look at his development, the child was above average in both motor and mental development at 6 months and 12 months after surgery. However, when he reached 24 months after surgery, which he was approximately 2 years old at that point of time, the motor development was on point, above average. However, mental development was average. So, but when you say average is a good place to be in. You're able to function well. You're able to do a lot of things that you would need, that your day demands. And his social quotient was superior. So whenever you talk to the mother, she would say, she's very happy with the way this child is growing up. The child talks to everybody, has good friends, is able to hold conversations with his doctors, and he's a very pleasant child when he comes into our OP as well. His intelligence quotient was 115, which is above average IQ. Now, when you look at this kind of development, though we know that children with heart defects are at a high risk of developmental disorders, this child actually tells us that there is hope and we can do so much better. But now let's look at Surya. Surya is somebody who has almost the similar diagnosis like Arav had. He also had his surgery in the beginning, 25 days of his age. And we followed him like we follow other children. Now, when we look at his development, at 6 months, there was motor development, which was average. Mental development was below average. And that went on until 24 months of surgery as well. Now, his social quotient was 95. So, when we say 95 social quotient, which means the child is doing okay, however, could have a little trouble in terms of maybe communicating with people or self-direction. What should I do in, my daily life? And when you look at all these areas in the social quotient, when we spoke to the parents also said that yes, the child does have trouble with attention. He has behavioral issues. He's not able to adjust very well in school setup. So this was something that we noticed in Surya. Now, what I'd like you to know about both these children is that there was no reported history of any known genetic syndromes or neurological disorders, any seizure disorders, or any other significant comorbid, challenges that could affect neurodevelopment independently. Even when you look at the family history of both of these children, there was no suggestive indications of any major psychiatric illnesses, no intellectual disability as such, or no neurodevelopment or hereditary neurological conditions also. Now, this background becomes very important for us because, it allows us to see this whole developmental outcomes and understand it primarily within the congenital heart disease and its treatment rather than having any kind of confounded variables, broader genetic issues that could be causing it or neurological issues that could be causing it. Now, if when you look at both these children, are you able to see my next slide?
Yes,
Yes,
Pranam.
yes,
All
yes,
right,
yes.
all right. Okay, so this comparison brings us to one of the most important realities in congenital heart disease care is that two children may have similar diagnosis. They may undergo successful surgeries. They may both survive very well, and yet there is the developmental futures of both of them could profoundly be different from each other. Now, this is the hidden gap that we have started to see in the CHT care. Now, if you look at it for decades, as we know, our focus has rightfully been on survival. And survival rates, if you look at it, has dramatically improved. Today, we have 90% of children who move into adulthood without any trouble. So the real question is, what happens after surgery? And is survival the final outcome, or do we have something more that we need to do? So, on that note, it becomes very important for us to look at, what are we missing out? Now, to begin this whole talk, I'm going to make it, I'm going to just take everybody through what our normal heart looks like. Like, again, this is more for my psychology friends as well who are here. Now, this is typically how a normal heart would function. We have four chambers, we have four valves, we have two great vessels. Now, all of these are meant to come together and function in a very coordinated way, and that happens for most of us. Now, the heart functions in such a way that the blue blood that you see, which is the blood without oxygen, is clearly separated from the blood with oxygen, and this whole circulation is supposed to come together in a very coordinated way. However, when we talk about heart defects, when we talk about congenital heart defects, what you would see is that you see on the right side. So this is one of the simplest forms of heart defects, which we call the ventricular septal defect. Now, here you see that the lower chamber, there is an opening, so there is a mixing of the blood that happens. Now, again, this is one of the simplest of defects that you can look at, and there are millions of possibilities when we say defects. Now, this is a very dramatic example, which you would see in a congenital heart defect. This is what we call the DTGA, where we are looking at the vessels that are meant to supply to lungs, to heart, and the body are switched. So the two vessels that we're talking about in Arav and Surya, this was exactly what they were going through. So these vessels were switched, and when that happens, you get blue blood into the whole body. Now, this is the most extreme form of congenital heart defect and would need an intervention, within a month of the birth. Now, like this, there are range of possibilities which exist. These are pictures that are given by, I've taken it from Dr. Balaji, who is a clinician with Amrita Hospital. Now, these are only a small fraction of what can go wrong. There are numerous possibilities of what can go wrong. And if you look at this, these are the conditions which would need intervention in the first 1 month. And then we have moderately severe CHD, which would require intervention by, say, 1 to 2 years, within 1 to 2 years of life. And then we have the easy ones where the survival into adulthood becomes possible. Now, bottom line of all of this is that when a child is born with heart defect, we can have conditions that can immediately threaten life, and those, you can live with them. Now, if you look at the whole field of pediatric cardiology, we have evolved, we've come too far from not being able to operate on newborns to where we are today, where, like I said, that 90% of these children are surviving into adulthood. But what are these numbers like? What are we talking about? How many of these children are we actually seeing every year? So 8 to 12 children out of every 1,000 births are born with congenital heart defect. And when we talk about India, we're looking at 2 lakh to 2,40,000 children being born every year with CHD, out of which close to about 20% require intervention during infancy. So this is how the numbers look like. Now, as we move on, it's important to understand, where we started from, where we are today. So I'm sure a lot of people will be able to recognize him. So would anybody know who he is? Except for KK sir, we're not asking him. Anybody else who knows who he is?
Move on. It's okay.
Okay, all right. So this man, Dr. Walton Lillehei, was the world's first person to have the open heart surgery. Now, what he did was extraordinary. He was extremely brave, I should say. So what he did is he used blood from the mother of the child and used that to circulate, and he closed a defect in a 3-year-old. And this happened in 1954. Now, why is this significant? He could have had 200% mortality, lost both the mother and the child. But again, his thought and his bravery actually gave answers to the world. Now, this was in 1954 where the successful open heart surgery happened. Now, from this date, 1954 to 20 years from then, there was a lot of work that went in. Before this whole concept of heart-lung machines came into existence, it was very difficult for children to be operated on, and you can't operate on the heart without stopping the heart. So it was very difficult, and the mortality rate was extremely high at that point. So when I say it was high, I'm talking about, so if say every 10 children who were operated, you would lose 3 to 4 children. Now, this is 1954 to the 20 years as time went on. Evolution happened, the technology evolved, and things got better. Now, what was happening here in India in 1970s, that's when the whole the focus towards pediatric cardiology started. So if you look at 1970s, we had only 4 institutions, large institutions, which looked at the whole area of pediatric cardiology. And if you look at these photographs that is there on top, starting with Dr. Tandon, who's also regarded as the father figure of pediatric cardiology, Dr. K.M. Cherian, and then we have Dr. Rao, we have Dr. Srivastava, we have Dr. Ramesh Arora, Dr. Iyer, and Dr. Sharma. So these were the names that you would hear in 1970s, 1980s, who actually brought up this whole field. And in 1970s, the surgery was pretty limited, but we moved into, during the first 1980s, we moved into having more accurate diagnostic facility. Echoes got better. The outcomes of operations got better. Infant VSD closure was possible. And in 1990s, finally, Dr. Iyer was the first one to do the open heart surgery in children. 1990s was also the period where pediatric cardiology now started, having its own identity. They became a distinct specialty in India. And that is also the period where we had, just a minute. Yeah. So before this, there was this period where we would see that because of the delayed diagnosis, the children would go through conditions where there was undernutrition, the lungs were affected, there was neurological brain damage, the consequences were pretty bad. And then came the period 1998, where Amrita Hospital, under the guidance of KK sir, so that is our young KK sir there in the picture. So he was the person who brought the pediatric cardiology into Kerala. And here the aim was not just about operations, or it was more to do with making bringing the whole concept to a good standard, where patient care was not just available but was also cost effective. It was accessible to everybody there in the region. And what KK sir has also done is that he is always, until this date, actually somebody who looks at capacity building. So at that point, training a lot of students was important, because it was also important to see many more children whom were missing out on this whole um, care, the timely care. So if you look at 1998, we had 1.3 to 1.5% children only who were receiving timely care. And there were just about 4 institutes in the country. And now in 2025, when you look at the right side of the map, all these red stars that you see that has increased are more of children who have, got trained from these pioneers, especially KKSA. KKSA students are all over the country today who are also operating. And we've moved from, say, 1,300 children being operated in the entire country in 1998 to 70 to 20% of the number that we're talking about today. So we've moved, huge. We've taken a huge leap, I would say, when we look at where we stand today in terms of survival. Now, in the by the early 1990s, what happened is that the pediatric care had achieved something extraordinary. More children with complex CHD were surviving surgeries. These were previously, they would not have been possible previously. But what happened here is that the survival also created a new reality, and that reality is what we're talking about today. For the first time during this period, children were not just surviving infancy, they were growing up. They were entering schools, they were entering classrooms, they were actually entering real world development environments where there were real demands and they had to meet all of them. And at this point, what happened is families also started noticing something very important. Some noticed developmental delays. Some noticed language problems. Some noticed that the child is having problem in adjusting in the crowd. Some saw emotional regulation troubles. Some also mentioned that maths was not easy or physics was not easy. And this is the period when the conversation started to change. Um, Now, if you look at this study, that Boston circulatory arrest study, now that was one of the most influential turning points in congenital heart disease care. And this became the landmark of the whole neurodevelopmental concept in children with CHD. This was led by Dr. Jane Newberg. I'm sure a lot of you must be knowing her. This pleasant looking lady there you see, Dr. Jane Newberg, along with Dr. Billinger, who is somebody who's very much interested on how children perform in real world setting, and Dr. Adre and the colleagues at Boston Children's Hospital actually did this study in the late 1980s, and it was a longitudinal study which went through 1990s. Now, what the researchers did here is they wanted to compare two operative strategies. One was where there was a total circulatory arrest, and the other one was low flow cardiopulmonary bypass, the LFPP that we call. Now, the expectation of them was to determine which technique offered better medical outcomes. Now, what emerged out of the study was far more significant. Dr. Bellinger actually took the neurodevelopment part forward and studied this. So, when the children turned 8 years of age, close to about 155 children were assessed. And what they saw is that there were few areas which were hampered. Motor functioning was something that was not doing great. Language development was had shown deficits. Executive functioning had shown deficits. Learning challenges were there in a lot of children. So this was something that Boston circulatory arrest actually brought forward. Um, However, one groundbreaking insight from Dr. Newberger's team work was that many children maintained average IQ. Though we did see deficits, most of them had average IQ. However, despite having an average IQ, what they saw was there still existed real world neuropsychological difficulties. Now this changed everything. So if everything is okay, if IQ is okay, if if you look at the majority of them, the composite score looks okay, then what is going on? There is something definitely more than that. So this again changed the whole concept of neurodevelopment. Now from here, if you in say in 1993, I would say the Western world started moving from survival to what is next. Is it only survival, or is it how these children are surviving? Now, if you look at these faces that you see here on the screen, they are the pioneers who thought beyond survival. They thought about, quality of growing up. So the first three of them, which I just mentioned, and then is Dr. Catherine. So Dr. Catherine said, I don't think it's the surgeries. I don't think there's anything to do with the surgeries. I think it is already, this imprint is already there before they're born. So she's somebody who studied the fetal brain in CHT. Dr. Adam, whom you see, he is the first neuropsychologist who studied executive functions in children with CHD. Now, uh, after say in 19 from 1993 to about 2012, this was a period where there was a lot of work that went through, and Dr. Bradley Merino from the American Heart Association, he consolidated all this work, and then there was a statement that was released in 2012 that said that, hey, this is what we see in children who are growing up. What we see typically in children with CHD is that close to about 40 to 50% show motor impairments. Now, delays are seen both in fine and in gross motor. But again, when you look at it very closely, you will see that these children have early delay, but as they grow up, there is a partial catch up that happens. Now, when you look at the mental development of these children, around 20 to 40% show cognitive delay. Often these delays are mild or moderate, and you won't see severe intellectual disability or severe deficits in intellectual functioning. So this was what the AHA statement put forth in front of the world. Now, as more work happened, there was a revision or an updation to the AHA statement in 2024 when a lot of studies started coming up. These children were actually growing up, and they're growing up into transitioning into adolescence and then adulthood. So at that point, there was an updation that happened with AHA statement, and there they mentioned that when you look at children with CHT, the mean IQ typically ranges between 85 and 100. And when you say 85 and 100, this is an excellent score to live your normal life, to excel. In fact, now 25 to 50% score below average range, which again is a range where you would be able to do your adaptive daily functioning that we call. Now, executive functions, that was the new term that we started seeing in CHD, executive functions. So just to give you a little bit of brief of one, when I say executive functions, what we mean is we have three basic executive functions. One is the working memory. So working memory would typically be that, say the mother says, can I go to the bedroom, pick up your shoes and bring it here? So this child goes to the bedroom and looks back and says, Amma, what should I pick up? So, that is something we see in working memory, where they're not able to keep information and simultaneously work on the action. Or if the teacher says, add 8 plus 5. So he goes 8 in the mind, 5 in the fingers. And then he's like, sorry, what was in the mind? Or if he has to copy notes from the blackboard, and the teacher has written, my pet's name is Moose. So he reads my pet and he writes my pet and he forgets what was actually written. So these little problems, that's working memory, one of the fundamental executive functions. The other one is the Cognitive flexibility where the child would not be able to understand another child's view. So, that leads to a lot of problems between friends. Um, when you have to switch between activities, like I was doing addition, but now I need to move to subtraction. So the child is not able to move from addition to subtraction. So these little things where we saw cognitive flexibility playing a big role. And then is the inhibition control, your impulsivity. So the child is not able to wait for his turn. He talks before the question is over, or he's not able to manage his frustration. There are outbursts. So all these areas were what started making a lot of noise. So when you look at the child, IQ is doing okay, but then there are areas that is actually showing out where there were deficits. And with children with CHD, what areas they saw was working memory was a trouble, planning was deficit, inhibition, impulsivity was there seen in children. um, then came the whole concept of neurodevelopmental disorders that was 2 to 3 times higher than the general population that was noticed. Learning disorders were also started showing out in the educational setup. Now, while all of this was happening in the Western world, in about at in 2020, KK was just mentioning about the ICMR grant that we had received. In 2020, we also, the work had begun in the mind long before 2020, because we had started seeing parents coming in, talking about learning challenges, talking about attention issues. So it became important for us also to see how this data is developing in, how is it looking like in our country. So at this point, at Amrita Hospital, Kochi, there was this concept of following the children after heart surgery. So they've had heart surgery in the first 1 year of their life. We follow them at three time points, 6, 12, and 24 months after surgery, and look at how they're developing. Now, of course, these 3 time points have gone up. We are looking at, following them up even when they are getting into adolescence and even further. Now, when this proposal was written, the sample size was 1,450, if I remember right. And but if you look at it, we have gone, about 2,500. So what we understood is that, this is not about the grant, this is not about the study, this is not about the 1,450 and meeting the sample size, but it's the whole answers that we started getting out of these out of the study actually were to the questions that we had not even asked. So we knew that the gap is bigger than what we think, and there are a lot of things that we need to look at. And we have been following these children even much after the study is, terminated with ICMR. Um, if you Let's just look at what our cohort actually started telling us. Now, when we followed these children at 6 months, 12 months, 24 months, we checked them for motor mental development at 6 months, 12 months, 24 months, and then further went on to understanding their cognitive ability, which is intelligence quotient at 3.5 years and then 4.5 years. Now we're also looking at measuring the executive functions as they're growing up. Now, what the results showed us in motor development was that at 6 months, we had close to about 24.3% of delay percentage. Now, at 12 months, this reduced. It reduced drastically. It went down to 13.9%. And then at 24 months, even further dropped. Similarly, when we looked at the mental development, 14% was the development that we saw, the deficit that we saw at 6 months, which went down drastically at 12 months after surgery, but not so much after 24 months of surgery. Now, what we did is also that we looked at the deeper, so we held a magnifying glass to see, okay, motor development looks like this, but are there specific domains in this motor cluster which is actually showing problem? So what we saw is that out of the domains that we were looking at, cluster domains that we were looking at, body control, which is holding up the neck, especially the neck control, body control, locomotion were the two domains that showed us deficits, very strong deficits at 53.1% and at 6 months, which definitely went down by the 24th month. They caught up by the 24th month after surgery, went down to 31.8%. Now, when you look at locomotion, walking and holding the body stable and putting your steps forward. It was 45.5% at 6 months. It dropped very much at 12 months after surgery. However, the deficits rose at the 24th month when we did the assessments again. So this clearly shows that the domains tend to emerge over time. When the demands increase from the world, we also see the deficits which we were not seeing before. And this is also something that the global data has shared with us, that when you look at a child with CHD, things could look pretty typical when they're growing up, but then as the child grows up and the environmental demands increase, they also tend to show deficits in areas that were not shown before. Now, when we looked at mental development also, two areas that show weakness in children with CHD is language. Now, when I say language, we usually look at language in two areas. So one is your receptive and the expressive. So receptive is somewhere not that hit, but when you compare the expressive, the vocabulary, the understanding, the language acquisition, especially the vernacular languages, is something that we see started taking a hit. So you see 44.5% at 6 months. It drops at 12 months, but then again, the deficit went up in the 24th month of assessment after surgery. Similarly, memory, 39.8%, the deficits in 6 months, and then drops and then goes up during the 24th month. So as a psychologist, when I'm screening a child and I get the deficits of language, vocabulary and expression and memory, I know that when the child is going to grow up, there definitely is a risk of school adaptation. Will the child be able to learn languages? Will there be issues with working memory? Would he have attention problems? And because these questions started coming up, when we further went in and checked for intelligence quotient, yes, the intelligence, the IQ test also revealed that the kind of areas that shows out, though the IQ compositely looks okay, 35 to 45% of children were within average and low average IQ, which is brilliant actually. 9.5% of children had scores in borderline range. And only about 5.2% of children had deficits in IQ. But when we look at it with the magnifying glass, the verbal acquisition, which showed out during the development as well, because during the development also, the vocabulary and expressive speech showed out as deficits. So here also the other areas looked fine, but verbal acquisition was a trouble, and working memory was again something which we saw the challenged area. So this is how our data in Amrita and the other satellite centers that we have tied up with has shown us in the study. So when we now look at how typical signature of neurodevelopment in CHD looks like, you would see that in the early phase, that is in the early childhood, the child might appear typical, and as the child moves towards a middle childhood, the variability starts showing up. And by the time the child is an adolescent, you would see a lot of other developmental demands that the environmental throws on. So here you'll end up seeing, the differences. They start revealing a lot of differences which was not seen in the beginning, which brings this whole question that if the child was doing okay on the test in the beginning, are we done? Or do we have to keep a follow-up till an optimal age where we understand if anything else is, revealing, and can we help them early? So these questions started arising, and we came to a conclusion that, the longitudinal, the developmental assessment that has to be done should become a part of the routine cardiac care in the pediatric cardiology setup. And that is why we are here today to talk about this conversation, which is very important for all of us today. So just to sum up what the neurodevelopmental signature looks like, one, it's uneven. It may look like something else. It's non-linear, and it emerges as the child grows up. The areas that you would usually see vulnerability in would be, postural or body control, locomotion, language, the more of the expressive language. IQ will usually seem preserved, but when you look at it with a magnifying glass, you would see that language as well as working memory could show trouble when we look at it in detail. So, this is the emerging gap, and that is why we are here today talking about it. We have developmental challenges. We are not able to meet gap between the schools and how we apply it in the school setup. There are behavioral and emotional challenges that we somewhere sometimes ignore, or we're not able to look at it as we should. Family functioning, or for that matter, even system level challenges, be it working in the hospital environment, knowing what should be done. In terms of, is it the right time to refer, is it not? So this is something that we have been facing pretty strongly now. However, whatever I've mentioned here today, we have a relentlessly working team who are looking at not just survival, but what is the quality of the survival of these children, and that becomes an important conversation. This is our team who works day in, day out to make to talk to more people, to build capacity, to talk to schools and parents. It's led by Keki sir and Manusa. And the core team that you see, we sit out of Amrita Hospital, Kochi, and then we also have satellite centers: Amrita Hospital, Faridabad, Badia Hospital, Mumbai, and Narayana Hospital, Howrah. So this is our little team. But whatever we spoke about today, I spoke about neurodevelopment, cognitive care. These are all somewhere seen. You can see them. But when does this all start? Does it only start during school? Does it start when the child is an adolescent? What we have noticed is no, it actually starts much earlier, right from when the diagnosis happens and the child is put into the hospital. The masked elements start from there, where you need a psychological intervention. So to put this understanding together, we have a little video. It's a 3-minute video which I'd like to play, where you can see a child growing up with CHD. Is it okay for me to go ahead and play this?
Yeah, yes, please.
Just 1 minute. Can you hear the audio?
We do.
Arjun was just 6 months old when he underwent complex heart surgery. For his parents, the surgery meant survival. For Arjun, it was the beginning of a journey no one could see. At 6 months, a baby understands the world through one thing: attachment. Suddenly, Arjun was separated from the one person who made the world feel safe. After surgery came days in the intensive care unit. Machines replaced touch. For a baby's developing brain, separation during illness can feel like abandonment, even when love surrounds them. The surgery was long but successful. Arjun's heart was repaired. In the ICU, parents watched from a distance. But when Arjun finally returned to his mother, something unexpected happened. He did not recognize safety the way he once did. When young children experience separation during stress, their brains sometimes respond with protest, confusion, and withdrawal. This is the mind's way of protecting itself. As Arjun grew, the scar on his chest slowly faded. Early medical experiences can also affect the developing brain. Some children may take longer to regulate emotions or cope with frustration. The trauma is not only the child's. Parents who nearly lose their child often become deeply protective, a response shaped by love and fear.
As children with congenital heart disease grow, they may also face hidden challenges in attention, learning, and social confidence.
But children like Arjun also show remarkable strengths. Many grow to become deeply resilient, observant, and emotionally aware. When families, doctors, and educators work together, children with congenital heart disease can develop the skills they need to thrive.
Heart surgery saves lives, but healing the heart is only the beginning.
can stop this now. I think the messages have come through in the previous. Yeah, thanks.
Yes,
So,
sir.
Sonam, I know we took a little longer than usual, but I asked Sonam to do much of what I was planning to do in terms of introducing the concept. So thank you for this. Vidya, with your permission, can I ask the next speaker to come in?
Yes,
Or
please.
would you?
Yeah. We might run out of time otherwise. So
Yeah, so Deepa, Dr. Deepa, I've introduced her earlier also. So can you just put the spotlight on Dr. Deepa and have her come? Yes. I think you can go on to slide share mode. Yeah, thank you.
Can you see the slide?
Yes, we can.
but there is
But
some problem with your audio. Do you have two devices on?
yeah, I think she has two devices, so you can turn off one of them, Vidya, Deepa.
Sure. Is it okay now?
Yeah, it's better.
Okay. Good evening, everyone. I am familiar with few people in the group. Dr. KK is one. Sonam is one. I'm not. I'm a hardcore developmental pediatrician, so maybe I'm the only pediatrician in this group. So thank you so much for this opportunity, and it's really heartwarming to see people trying to ensure, what should I say, it not just survival but quality survival. That's where it's really heartwarming to see cardiologists coming in. I was really impressed by the work being done in Amrita. So my short topic would be on why composite quotients do not really tell the true story. So we are all actually, whenever we talk about a child's school performance, we are all hooked on the concept of IQ. So IQ is actually a numerical score which actually tells you what your potential really is. So just because we have a potential, that doesn't mean we should be living up to it. There are a lot of factors which play a huge role in whether we reach our potential or not. The simplest thing, whether we have the exposure, whether we have the means. So just because you have potential doesn't mean you have to do well. So IQ is routinely measured by standard tests called Binet Kamat test, Wechsler scale. So there is another main area which is called a neurocognitive function. So what exactly are the neurocognitive functions? Neurocognitive functions are the functions which tell you, how can I do it? So just having potential alone does not matter. You have to have a balance between IQ as well as neurocognitive functions. The previous speaker, Dr. Sonam, actually touched on neurocognitive functions. So I would just go into it a little bit in depth to tell you as to what exactly neurocognitive functions are and why should we move beyond the concept of just IQ alone. Now, this is just to tell you about IQ. We were talking about numbers even previously. The mean IQ is actually 100, and it is expressed in a standard deviation of plus or minus 15 usually. So very superior IQ is in a 130 to 160, which is very high. Superior would be around 120, between 120 and 129. High average would be between 110 and 119. Average would be around between 90 and 109. All I want to say is that it is a huge range. And to say that a child is intellectually disabled, his IQ actually should be less than 70. Does that mean all the children with IQ above 70 are going to do exceptionally well in school? The answer is no. We have got a huge category between 70 and 85. They are actually called slow learners. And they actually really struggle in school. So having a normal IQ doesn't mean that you can do well in school, because the range is quite wide. And this group of children between 70 and 85, actually, they are in a no man's land. They are not eligible for a disability certification because their IQ has to be less than 70. They are not eligible for a specific learning disability certificate because their IQ is below 85. So this is a huge, most of our children with poor school performance actually fall in this range between 70 and 85. Now, let's just go into neurocognition. Neurocognition is actually a multi-dimensional process which is very critical for effectively responding to the environmental stimuli. If we have to respond effectively to any stimulus in the environment, our neurocognitive functions have to be intact. Now, some of the neurocognitive functions are executive function, attention, processing speed, your memory, your visual-spatial. These all look like complex terms, but they are in fact very, very simple. Let's just go through each of them briefly. What are the features that we get when we have executive function defects or attention defects, and how can we actually remedy? Now, as you can see, it is a very, very complex process. It's a top-down guidance where your motor cortex is involved, the sensory cortex is involved, you have got the basal ganglia involved, hypothalamus involved, amygdala, cerebellum, multiple structures of the brain are involved in neurocognition. So, and there are multiple connections between all these areas. So when you have a child with poor school performance, especially post-cardiac surgery and all that, you may not find structural damages in the brain, but these connectivities between these areas may be affected, which will not be routinely picked up in a routine MRI scans. As we all know, we may need functional MRI scans. But all I'm trying to say is that even if you don't have a structural defect, these connectivity between these areas may be impaired in these children. Now, as was mentioned earlier, executive function has three major functions, mainly components rather: working memory, your inhibitory control, and your cognitive flexibility. Each of these components is extremely, extremely important for the child to perform well in school. What exactly is working memory? As Dr. Sonam had mentioned earlier, working memory is actually a short-term memory. If you have good working memory, if all of us have good working memory, you should have an idea as to what I had mentioned in the previous couple of slides. That's all that working memory means, your immediate memory or your short-term memory. And from there, actually, memory gets consolidated into your long-term memory. Then, what is inhibitory control? Inhibitory control is very, very important in that a child should be able to filter his thoughts. If he is sitting in the class, he has to concentrate on the class. He should be able to filter out all the background noise and concentrate on what he's meant to concentrate on. It is very important for focused and sustained attention, as we all know is very, very important for academic excellence. You should also be able to control your impulses. You should also be able to wait for your chance, wait for your turn. So are these features of ADHD? Yes, these are features of ADHD. ADHD children also struggle with executive functions. Cognitive flexibility, as was mentioned earlier, is your ability to see beyond rules. For instance, in grammar, we have certain set of rules. If you add ed to most of the verbs, you get the past tense. But we all know that there are exceptions. Like would be liked, want would be wanted, but run is actually ran, come is actually came. So only if the child has cognitive flexibility would he be able to work around the rules and have a flexible way of thinking. So these are the three main executive functions which children post-cardiac surgery may be defective in. How do these poor executive functions clinically manifest? How would we pick them up? They have challenges in attention. They have a difficulty in emotionally regulating themselves. Earlier, the previous speaker was talking about expressive speech and receptive speech. Only if the child has the ability to speak, or only if he's able to express his opinions or express what's on his mind, would he be able to communicate with his parents and tell them, I'm feeling upset, I'm feeling angry. So the child should have very, very good expressive language capacity. Only then can he have attention, can he be emotionally regulated. As I said earlier, these children who have very poor executive functions would be very impulsive. They will be, even before you ask the question, they'll blurt out the answer. They are unable to sit in a place. They will be fidgeting all the time. I find it difficult to make friends because they are so intrusive in their talk that children will not put up with them. They want to keep on talking about their favorite subject. They're not willing to listen to another person. Very difficult for them to sustain and maintain their attention. Now, how can we improve the executive function? As I said earlier, make sure that the child has a very good language base. Language development is very, very important. Emotional regulation strategies. Emotional regulation, you should actually teach the children first to identify their emotions. The children might not even know what is it that they're going through. So you may have to show them pictures of happy faces. Is this what you're feeling now? When you are happy, this is what happens to you. You show them an angry face, tell them this is what you feel when you are angry. So understanding emotions, you may have to start from the base, helping them to even recognize their emotions. Structured play, which is very, very important. Executive function is where you have to hone all your skills in a goal-directed way. So, making a puzzle, you have to follow certain rules. So putting things together to make something following instructions. Those are all goal-oriented activities. Such activities will help to improve the executive function of the child. Let's go on to the next neurocognitive function, especially attention. Attention is very, very important. Unless you are able to focus your attention and sustain your attention, it will be very difficult to do well academically and even otherwise. A rough figure to remember is, if you have a 2-year-old child, the attention span of the child would be anywhere between 4 to 6 minutes. You have a 5-year-old child, it would be anywhere between 10 to 15 minutes. That's just a rule. Doesn't mean that it has to be like that. It can be more also. So the maximum is around 5. So if you have a 2-year-old child, you cannot expect the child to sit with you and do an activity for half an hour. His attention span maximum is around 10 minutes. So you should not be pushing the child beyond his limits and then saying that he is having an emotional dysregulation or whatever. You have to understand that his attention capacity or his attention span is limited. So there are several factors which, if you have a child with inattention, it is not exactly, you have to find out whether, is he tired? Is he hungry? Because if a child who is hungry, a child who is tired, his attention span will definitely be below par. Another thing is adenoids. We very commonly find children with adenoid hypertrophy. These children have poor sleep because they have snoring, they have got sleep apnea, so their sleep quality is very poor. So what happens to even us if we do not have good sleep? We get up irritated, we are very irritated, we get angry, we don't have attention. That's the same thing that's going on in him. So if a child has inattention, don't label him as ADHD. Rule out all these possibilities. Is he having, adenoid hypertrophy? Before you label him as ADHD, rule out all the medical conditions as well. How can you enhance attention? Optimizing the learning environment. When you have a child who's very distractible, put a table in a corner where he is not distracted. There should not be any calendar or anything hanging on the wall. He should not be made to sit near a window because chances of him being distracted are more. So you can always change the environment so as to improve the attention of the child. You can make his tasks very structured. Don't give him a very vague instruction like clean up the room. Split it down. Arrange your books, arrange your clothes, fold your bed sheet like that. You have to split up the tasks. Your what the commands should be very precise, very clear, with minimum possible words. You always have to make sure that, as I said earlier, the child has adequate sleep, which is very, very important in a child, at least 9 to 11 hours of sleep. Then give him movement breaks. If his attention span is only 10 minutes, after 10 minutes, give him a movement break. Let him run around, let him do a couple of jumping jacks or bounce on the exercise ball. Do some activities so that his attention is actually brought back. So these are all easier said than done. You can imagine a teacher being asked to do all this. She'll be having around 10 ADHD children in her class. But these are some of the easier ways in which you can do it. And in a class, the creative way would be ask him to get up in between to to wipe the board. So it gives him a time to get up and walk around. He can be asked to distribute the books. These are all ways in which we can give him a movement break in class as well. Now, visual construction and perception, the concept is very, very simple. If looking at the board and copying down notes, it's something which we take for granted. But for a child who has got poor neurocognitive functions, it's a huge task. Looking at the board and moving his fingers accordingly to write whatever he's seeing on the board. So most of the children, their notes are incomplete. They have bad handwriting. They don't leave margins. It's because they have very poor visual-spatial organizational skills. Another skill is understanding what is in front, what is prepositions, on, under, behind, in front. For instance, if you look at very simply small b and small d, the little hump is on the right side in B and on the left side in D. For a child with neurocognitive dysfunction, it is very difficult to find out where to put the little bump. So these are all very, very simple things, but very difficult for these children with poor neurocognitive functions. The visual memory helps the child to recall what he has seen, spatial relationships we mentioned, figure ground perception. You have a crowded figure. From that figure, the child should be able to pick out whatever you ask him to do. If you remember, I don't know how many of you would be familiar with small magazines like, we have something called a Magic Pot, which is a small book which gives all these skills for executive functions. It's a beautiful small book. You have got mazes in it. You have to find out the differences between pictures. You have to pick out apples from a huge jumble of things. So those are all simple things which would help to improve the visual construction and perception in the child. Visual closure is something else. Even if a child is shown just the trunk of an elephant, he should be able to say it's an elephant. He does not have to see the entire picture to say that it is an elephant. These are all simple things which we all take for granted. But for a child with neurocognitive dysfunction, all these are major hurdles. So these are some of the cues which tell us that a child has got poor visual construction. Inversion between B and D, P and Q, 6 and 9, poor spatial organization. He will not be able to write within the 4 lines. His letters would be very big, macrographia. He'll cross the lines. Then he has difficulty in finding objects from a jumble of things. So how can we improve it? Simple activities like, giving jigsaw puzzles are very, very good. Copying shapes, finding out the differences between pictures. Then memory cards. You have got cards with pictures. You can place the cards actually with face down, and you pick up one card and ask the child to match it. So he has to remember where the other card is. He has to have good eye coordination. These are all simple things which help to improve the visual construction and perception in these children. Last, and the neurocognitive function which I would like to talk about is the processing speed. Processing speed is I say something, how much time does the child take to understand it? Now we know in a class, the teacher will be talking at a very rapid pace and the child has to have good processing speed if he has to imbibe what the teacher is saying. This also becomes very important in conversation between friends. The friend would start off on a topic, he may crack a joke, but by the time the child understands the joke, they have already passed on to the next joke. So such a child, is he going to fit into a group of peers? The answer is no, because he will be seen as a dullard and slowly they'll push him out of the group because he is not able to grasp what they're trying to say. That is the importance of processing speed. And in maths also, you need fairly average processing speed to understand and, work through complex maths problems. Now, how do we actually handle children with neurocognitive dysfunction or neurocognitive impairment? Give them extra time, repeat whatever you are learning so that they understand the concept. Try to reduce the workload for them, make the learning very structured, provide very clear outlines, given the option of writing, something called telegraphic answers. With bullets, he can be asked to write just the point instead of writing an essay. Maybe try and have a different way of assessing him rather than a written answer paper. If he can be assessed orally, that would be very good. Minimize the distractions. So these are all some of the ways in which we can suggest, but our school system is still mark-based, writing-based. So we have a long way to go before we can make this actually, acceptable to the education system. But with, people who are really and truly into this field, I hope we can all make a difference in this. I think that's my last slide. Thank you all for this opportunity, and I hope, at least some of it I've been able to express myself and able to convey the importance of neurocognitive function to all of you. Thank you once again.
Thank you. That was very, very wonderful and extremely. I mean, I listened to it again, and each time I'm getting so many insights. Dr. Vidya, I'll have you guide us for the remaining time as to
I
how
think
we should do it.
we have some time, so maybe you can just put it all together. In
Um,
five or
yeah,
10 minutes. Yeah.
no, I think firstly, of course, Sonam introduced the problem that we had started to see over the last 25 years and gave it a very clear coherence and also talked about the work that we were doing in the last 7 or 8 years in terms of looking at the cohort of children who have been operated. But the reason I thought it will be of interest to Marvelous Medicine is because it matters to every other jurisdiction, isn't it? I mean, there are almost every aspect of pediatric care where there are chronic illnesses or there are interventions where this problem that you see in children with heart disease, I'm sure it must be a problem with those children as well. So I just wanted to know how this resonates with the other specialities and hear their thoughts on this as well. Maybe I can start with that and have that discussion and we can use the experts who are here to have insights provided for their specialties as well. So if there are other pediatric specialists who listen to this, and maybe they can talk about what they think about it in terms of how it applies to their own respective specialty.
Actually, one of the things that immediately struck me when I saw your, sort of framework for the thing, I thought immediately of left lip palate for some reason.
Yeah.
That, similar kind of, though the original diagnosis is not as life-threatening as cyanotic heart disease, but, so I'm not sure if there are
No, it's
any.
a very good example. And the reason why it's a good example is cleft lip palate is often associated with specific syndromes. For example, there is a very clear association with catch-22, which has a whole series of neurodevelopmental consequences. So it's in one way, it's just a marker. In another way, of course, it affects speech and it would affect, it would also lead to a lot of disruption from the child's usual trajectory. So I think, again, I'll ask Deepa maybe to dwell on this point. The example of cleft lip and palate, what sounds relatively simple and straightforward, I'm sure it has serious developmental implications.
You're
You're
muted, Dr.
muted.
Deepa.
Can you unmute, Deepa?
Sorry. Yeah, you were asking about the developmental implications in cleft lip
Yeah.
palate. Madam Dr. Vidya, as Dr. KK said, cleft palate in isolation, we do get cases. And some of them, I'm sorry about my dogs, please do forgive them. Yeah, we do have midline defects are more common in the brain as well in these children. So, isolated cleft palate children usually do well, but they may have speech issues. They may have recurrent otitis media. We commonly see speech issues in isolated cleft palate, but if they have an underlying syndrome, their neurodevelopmental outcome may not be as good as in an isolated cleft palate alone.
Ravi Shankar, you had your hand up.
Yes, actually, Dr. Deepa's comment really it offers a perfect segue. So, are there any neuroendocrine problems in these children? Growth, development, puberty, delayed puberty, precocious puberty? Are there any studies that have looked at that? I know that there are plenty of studies that have looked at obesity in survivors of congenital heart disease surgeries, and it is actually quite high, much higher than even in the general population, which is quite staggering in itself. But in this group, it is even higher. So I'm wondering if there are any like growth hormone defects in gonadotropins, if that has been formally studied.
Not that I'm aware of. In the space of congenital heart disease, maybe that is something that might happen in the future. But at this point, our cohort that we are following is relatively recent. So none of them have reached adolescence. So we haven't really started to look at it specifically. But generally, yes, of course, we've got lots of challenges relating to adolescence in specific areas. For example, children who have had a Fontan operation, who develop protein-losing enteropathy, they have a host of abnormalities that result in from a variety of hormone imbalances. Their puberty is delayed, and definitely growth is affected. Not We've studied growth actually quite extensively. We haven't found. I don't think we have found defects that could ascribe those that could be attributed to growth hormone deficiency. We haven't seen that, but we haven't really studied it in that depth.
Thank you.
Dr. Deepa, you have any insights on that question?
No, madam, I need to look into that. I've not actually looked into that area.
Dr. Amma, you have your hand up?
Yeah, good evening. I'm a development pediatrician myself, and in Children's Hospital, we also started a study of following up children with congenital heart disease post-surgery, but somehow it didn't really take off. I just want to know whether there was anything common in the MRI findings. I don't know if it was mentioned and I missed it. In these children, did you do an MRI as a routine in those children who had delay? And if you did you have any common findings in that?
No, we don't do MRIs in the ones who are just delayed, because the prevalence of delay is quite substantial. If you look at, and if you start to do MRIs, we would not have the resources. Also, more importantly, the MRIs don't really change anything or really give us specific clues, as was mentioned earlier. You may have a perfectly normal, regular MRI. You'll have to do a functional MRI to identify the problems. So we haven't been doing that. We have significant resource constraints. So all these follow-ups are actually supported by grants. Patients are unable to pay for them.
So, Gayatri, would you like to come in at this point? Gayatri Mahajan?
Hello.
Hi.
Thank you so much. Excellent talk. And I'm so happy to see so much work being done in India. I mentioned in the chat that routine developmental follow-up for these high-risk congenital heart disease babies is routine up to the age 3 in the US, but it rapidly fades off after that unless you have a grant or you're in a specialized clinic, and it's up to the family. So we actually spend a lot of time counseling families about all the things you talked about, potential executive function deficits, long-term outcomes and everything at age 3, hoping that they'll remember this for the rest of their lives, because unfortunately, even in the US, long-term follow-up is rare unless it's outside a specialized clinic or a study. But this is really important to keep in mind and to counsel families, because unless they have that awareness, they will not seek the help or provide accommodations. But thank you.
Shiva Pillai, you have your hand up?
Sorry. So I'm trying to unmute first. Fantastic talk, very interesting. I do fetal medicine, and to an extent, we are reading a lot of this now, where it became quite a big thing to do a lot of interventions intrauterine, especially now, for spina bifida, there is intrauterine interventions. In ventriculopathies, there is intrauterine interventions. But now what is coming to the fore, and the latest journals were showing this, is that many of these children have a huge amount of neurodevelopmental disorders despite adequate intervention, and the surgeries are considered successful in the sense that they they give you a healthy child, but they get neurodevelopmental disorders. But another thing that we are finding right now in prematurity, when we have premature babies, especially in a lot of premature babies now, babies that need long-term ventilation and other things like that, they are definitely having a higher rates of neurodevelopmental disorders, and we are following up children of that. Because I do the prevention of PET, preeclampsia, and we have a lot of babies delivered preterm. We are actually finding that finding also. So it is interesting, now that it's being followed up properly, one needs to look at whether we could do more for these children by getting an earlier intervention and to make things better for them. Because we always intervene, correct the problem, but don't think about subsequent development of the child. And I think we have to pay more attention to this. So it's very eye-opening for me and a very interesting talk. I must say I will have to do more homework now in how we follow up these babies. Thank you very much.
Venkatesh, you had a lot of questions. Do you want to say something now?
Yes, ma'am. Excellent talk, and it's very informative and very educative as well. And my question is, I mean, I'm a nephrologist, so I don't know much about these kind of illnesses. But I see a lot of kids being treated with polypharmacy. So one of the questions, maybe a very late question that comes to my mind is are these disorders the domain of psychiatrists who tend to use drugs, or psychologists who tend to use different kind of therapeutic approaches? That is question number one. And two is, there is this term neurodivergence, which is often quoted in many aspects, and even in common parlance, people use this term, bandy this term very commonly. So, what does this neurodivergence actually mean?
So I think Sonam or Deepa can answer these two questions because they had explained very nicely both neurodivergence as well as the other issue of who do you give medications to.
So to just answer what neurodivergence would mean, I'll just put it up in a very simple language here. It means that the person's brain works a little differently from what we would define as typical. Which would affect the way the person thinks, the way he learns, the way he behaves, and how does he interact with his system. Now, what examples here would be like autism, ADHD, dyslexia. All of this are neurodivergent conditions where your attention is affected, your learning is affected, social interaction is affected. So that is what we typically call neurodivergence. Deepa ma'am could add on to this as well.
Dr. Deepa?
Actually, the concept of neurodivergence, doctor, we call ourselves neurotypical, okay? And we label an autism child, an ADHD child as neurodivergent. But for them, we are the ones who are neurodivergent. They think of themselves as neurotypical. Some of the verbally autistic children, they are very comfortable being socially withdrawn, not communicating with others in their own world. They are highly satisfied, and we are the ones who are trying to bring them out, saying that you should be like us. We are the ones who are neurotypical. You are the ones who are neurodivergent. They don't agree. So this concept of neurodivergence is the way we look at it, actually. So a child who's behaving differently, a child who's not communicating according to our so-called social norms, we call them as neurodivergent. But from their point of view, they don't think of themselves as different. They are saying, why don't you meet us halfway? You think of yourself as normal. Why don't you meet us halfway? So neurodivergent basically means like they are not according to the typical so-called socially acceptable child who behaves in a so-called defined way. So anybody who behaves differently is called as a neurodivergent. But there are a lot of neurodevelopmental disorders like ADHD, ASD, your specific learning disability, your speech and language impairment. All those children are actually neurodivergent because they don't fall into the category of exact neurotypical people. And polypharmacy that you were referring to, what exactly do you mean? Do we start medications immediately when we see an ADHD child? The answer is no. It's always, especially in smaller children, younger children, children less than 6, we always go for behavior therapy, parental training, teaching them the skills to occupational therapy, all that will come into place. In an older child, maybe we may try medications along with behavior therapy. So do we straight away go to medicines? If it is a very severe child who's got very poor sitting tolerance, unless and until this child is able to sit at least for a few seconds, none of the therapy is going to be effective. So you take a call. If the child is extremely disruptive, not sitting at all, then you may start with medications and therapy. Otherwise, it's always therapy first, and then if the child is not improving, we add on medications. I hope I'm clear there.
Thank you.
So, Ravi Shankar put this in a chat, and Sonam has answered, but not everyone might have looked at it. So, in a recent talk on traumatic brain injury, we were told that brain defects in brain injury are not static, and so he was asking whether brain defects in these children are also not static, or is it static like CP, or how do these defects progress?
Sonam, you can re-answer that. It was what you've written is very nice, but you can say that again.
Yes, sir. So what we have seen in literature is that brain vulnerability is, largely seen early and is mostly static. These usually arise from infancy-related insults, prenatal or preoperative, variables, rather than progressively degenerative, like worsening neurological disease. So that is what what I've understood from literature.
Right.
Brain continues to develop. So these early differences also can lead to, the altered maturation of neural networks, especially when we look at executive functions, when we look at attention and, the adaptive systems. This is something that we will see. The deficit starts to appear more prominent as a life starts demanding more out of the person.
Yeah, so you did mention that there is evidence now that there may be changes in the brain or development even before
Yes.
birth.
Yes.
So Venkatesh had another question: is the relationship between surgery and anesthesia exposure and neurodevelopment anomalies an association or causal? So do you have a control group?
No, we do. So that the famous study was the Boston circulatory arrest study, where all these factors were looked into, and there were various kinds of control groups that emerged, and there are similar studies of this nature. So the thinking now is that it's obviously multifactorial. Uh, there is definitely influence of of medications that are given in the ICU, of anesthetics, of even small plastic products that come out of the tubings that are used for infusion, microplastics. All kinds of influences are going to these children, but it's very difficult to tease out what does what. Definitely, these children have an inherent issue, which may be genetic. They have a fetal issue. They're exposed. Their brain is exposed to a lower saturation or a different kind of perfusion pressure during development. There is trauma, and there is exposure at birth, and there are all kinds of insults preoperatively before the child actually has surgery in terms of hypoxia, reduced perfusion. Then there is surgery, there is cardiopulmonary bypass,
Only you guys
there
are
is
quite fucking
intensive care,
great.
there
All
is
these
intensive,
pediatric surgeons and all.
sorry, and there is
Uh,
intensive care as well. So there is so many influences. and it's very difficult to tease out. The one thing definitely has emerged is that surgery isn't as bad as we thought it was. Whether it's circ arrest or cardiopulmonary bypass, maybe it's one of the lesser influences in these patients with congenital heart disease, especially the modern surgery, which is evolved to a certain level that children are brains are actually subjected to a very minimal amount of insult. So it's very difficult to tell, but definitely all these factors they add up.
Right. If anyone else has any questions or comments, please raise your hand or turn your camera on in case we've missed your question or comment in the chat box. Not over to you, Radhakrishna. Oh, there, Venkatesh, you have a hand up again.
Yes, ma'am.
Yeah.
One of the common questions that we have to encounter is about vaccination. Is vaccination and neurodevelopmental anomalies are really linked? Can somebody set the facts straight?
Huge controversy. I mean, obviously, I'm not in the. I would like Ravi. Maybe he should. He's very eloquent about this. Ravi Shankar, you can put this in very good perspective on whether vaccinations have. Or if Ravi is not available, maybe Doctor. Yeah,
No,
Ravi is
sorry.
there.
I was hoping you wouldn't put me on the spot, but
I'd
since you
love to
said,
have you because
I,
you've expressed yourself on this very nicely.
no. So actually, I do believe that a lot of this, a lot of the literature on vaccination and and things like autism came out of an English researcher's garage where he made up the data. He has since confessed, and the paper has been withdrawn. But the seeds of disinformation have been sown, and they're not growing into shrubs. They're growing into humongous trees with aerial roots, which is really sad. So all of this is based on somebody's imagination and not a very good imagination per se. There is very little information to suggest that there is any connection. And I will ask folks like Dr. Deepa and Gayatri, if she's still on, to also add to this. It is really hugely inappropriate to consider vaccinations as harmful. Yes, they have side effects. They are like any other drug. But when you do the benefit risk analysis, it is always it always falls in the favor of benefits.
I can add to that, and I completely agree what Ravi said. There is no evidence whatsoever. Again, you'll hear of these anecdotal reports of somebody having a major side effect due to vaccine or losing function. But again, it's a risk-benefit ratio. Vaccines save lives. That's as simple as that. Even in a Western country like US, we have had large-scale measles outbreaks and people have died because of vaccine preventable diseases. So it's always a risk benefit ratio, and you have to look at evidence. You cannot go by anecdotal reports. You look at evidence and see what is the evidence for everything that we recommend, right? So, we know that vaccines are safe and they do not cause autism. We get this question, I get this question all the time as a developmental pediatrician. And I tell people I would not vaccinate my children if it was dangerous, right? So,
Right. Thank you, Gayatri. Over to you, Radhakrishna.
Just one last comment, Vidya, if you don't mind. Just one thing. The reason why one thing that I wanted to come out of this whole episode was the fact that medicine, especially in India, the way it's being compensated and the way people are looking at it, has become very procedure based. People tend to gravitate towards specialities where you're compensated for procedures and don't think beyond doing something. What we've learned from our journey is that that's a very short-sighted approach. It's not just enough to do surgeries or whatever interventions, or it's so much more in the life of the patient than and this is just one little thing that gets disproportionately compensated. So this is again to raise that awareness amongst pediatric cardiologists, especially. Thank you.
Yet another interesting talk, yet another pearl, I should say, in the Marvelous Medicine series. Actually, I'm a surgeon, and this is something very, very new to me. And now I have two questions. One is that now that a connection between surgery for congenital heart disease and neurodevelopmental defects is found out, how is it? What is the clinical application of this knowledge, and how are we improving the future generation of pediatric patients with congenital heart disease undergoing surgery?
So we are actually seeking to come up with a whole series of early interventions. We've just started to understand the nature and the extent of the problem, but obviously we'll have to generate evidence about the nature and the type of early interventions that make a difference. But just going from all the other areas where we've seen and the fact that there is such room for neuroplasticity, we firmly believe that we should start doing something when we identify very proactively rather than wait for the child to actually show up with these defects. So this is the main lesson that we really want to come up with. And this, of course, will require tremendous commitment from the clinicians, a great multidisciplinary team, and a lot of parental cooperation. But we have to do it.
And my second question will be, is there any difference in the incidence of this neurological problem between patients who underwent surgery and patients who underwent percutaneous procedures with cardiac conditions?
Yeah, there are some studies that seem to compare them, but then it's apples and oranges because interventions are done for relatively simple procedure conditions where you don't have the room for too much of neurological insult. Whereas surgery is done for the most sick, the most critically ill babies. So it's very difficult to make the true comparisons between the two. Unlike in cardiology, you can compare PTCA versus CABG. You can't do that in congenital heart surgery, in congenital heart care.
Thank you, sir. Wonderful evening indeed, Vidya.
Your closing comments, Sonam.
Sonam, your closing comments. I don't think you prepared yourself for that, but you can close out.
If Sonam is getting ready with her comments, over to you, Dr. Deepa, your closing comments.
It was really wonderful interacting with all of you. And I think Dr. Leela Kamath is also in this group. Madam was my, what should I say, mentor when I started my journey in pediatrics. So it's really wonderful to see that Madam was also here. As I said, it's always heartening to see people moving beyond, looking into development, because development is not an area many people are interested in. And I really have to appreciate Dr. KK for the effort that he has taken there. And when I was talking to him, it is not just congenital heart disease alone. Children with type 1 diabetes, children with leukemia who undergo chemotherapy, especially children who have, have been subjected to radiation, children with sickle cell anemia because they have relative hypoxia there. All these children have neurocognitive issues. So children with chronic diseases miss out on school as well. So it's actually multiple factors are playing there. And like previously was mentioned, helicopter parenting. So these children are extremely vulnerable, and unless and until, people who are taking care of chronic illnesses in children are aware that, we have to look into development. Only then will we actually work on these children and actually give them a better quality of life, not just for them, but for the parents, especially the mother. So I really and truly appreciate the work that's being done in Amrita, and I hope this will open up avenues everywhere else. Other people also would be involved in, concentrating on the developmental aspect as well. Only then can you really give a good quality of life to the child. Thank you.
Colonel Harikrishnan has mentioned that it might be interesting to see the neurodevelopmental aspects of infants who survive other life-threatening defects like, tracheostomy, fistula, or, spine or orthopedics. So your point is well taken, ma'am.
Yeah, it's Dr. KK's point. Actually, he mentioned this and he asked people in this audience. I'm not qualified to speak on it, so I thought it's worth mentioning it. Thank you.
Sonam, are you ready now?
Yes, I was actually talking with the mute on.
Your
Yes.
camera was off, so we couldn't figure out.
Right. So, I mean, I would, first of all, thank you, ma'am, for this whole platform where we could talk and converse on this important topic. I would like to end by saying that, I think the first step in pediatric cardiology itself would be to stop seeing neurodevelopmental follow-up as an option. I don't think it's optional anymore. For every children who have lived with CHD, survival is only the first milestone, and we have so much more to see post that. I think that is what is important, and also because we have a lot of pediatricians and the doctors here. I'd also like to make this point where if pediatric cardiologists and pediatricians, developmental pediatricians, can play a role of becoming more like the first point of developmental triage, I think that would help a lot. They don't have to do everything, but they can identify risk, explain the importance of what exactly needs to be done to the families, and refer early. Because when we look at the signature here, the signature is dynamic, it's evolving, and we wouldn't know what it would show out later. So I think that is what makes a big difference.
Thank you, Sonam, for putting it all together so crisply. And over to you, KK.
Well, just a big thank you, Vidya, for the platform, and we've enjoyed the interaction with very diverse group of highly enlightened, marvelous medicine attendees. Thank you so much.
Thank you, everybody. We'll meet again next week with another episode of Marvelous Medicine. Till then, take care and stay safe.